As the Northern Hemisphere enters winter, public health networks monitor the annual escalation of respiratory viruses. We are currently tracking the 2024-2025 influenza season. To measure the primary defense against this spread, the CDC utilizes the Morbidity and Mortality Weekly Report, or MMWR. This document provides the initial interim estimates for seasonal vaccine efficacy. These findings are derived from a documented baseline cohort of 50,000 adults, tracking their vaccination status against clinical outcomes. Collecting this data midway through the season allows epidemiologists to perform vital course corrections. It offers a real-time assessment of how the vaccine performs against currently circulating strains. Evaluating that performance requires an analysis of layered disease burden reduction. The goal is to observe how the vaccine mitigates damage at different stages of exposure and infection. Accurately interpreting these early metrics allows public health analysts to deploy targeted strategies before viral circulation reaches its midwinter peak. Within the broad dataset of 50,000 individuals, the CDC report isolates a specific demographic parameter requiring immediate clinical attention. The analysis filters for a precise cluster of 40,000 adults aged 40 to 70. In this demographic, baseline immune response steadily degrades. This decline compounds physical risks, significantly increasing the probability of severe secondary complications once influenza takes hold. The CDC's interim analysis maps exactly how well the seasonal vaccine protects this specific high-risk group against those escalating threats. Securing the clinical outcomes of adults aged 40 to 70 prevents severe cases from compounding and systemically overloading hospital networks. We can now examine the quantitative findings extracted from the 40,000-person cohort. Relative risk reduction, or RRR, measures the percentage decrease in the risk of a specific outcome in a vaccinated group compared to an unvaccinated baseline. We track two separate metrics: standard infection and severe hospitalization. The data shows a 45% relative risk reduction for contracting a baseline influenza infection. For a practitioner forecasting patient caseloads, a 45% reduction means nearly half of the expected outpatient visits from this demographic are successfully prevented by the primary immune response. There is a separate, distinct 30% relative risk reduction for hospitalization. Preventing severe disease is a different physiological battle from preventing the initial infection. Clinical practitioners prioritize the 30% hospitalization reduction. Keeping high-risk patients out of intensive care dictates the overall survivability of the public health system. The vaccine operates as a stratified defense system, mitigating severe systemic damage even when the primary barrier to infection fails. This gap in efficacy brings us to a persistent communication hurdle: the perception that a breakthrough infection means the vaccine has failed. Post-vaccination infection is an expected statistical probability. It is a biological limitation of current vaccine technology. This simulation shows mucosal immunity, the localized defense in the respiratory tract. When a patient encounters a highly concentrated wave of viral particles, this initial porous threshold can be breached. Once that breach occurs, the vaccine-primed T cells in the secondary immune response activate to aggressively downgrade the rate of viral replication. This biological downgrading restricts the virus from effectively damaging deep lung tissue, which secures the 30% reduction in hospitalization risk observed in the CDC data. Against rapidly mutating respiratory viruses, absolute binary immunity is biologically unattainable. Professional communication should focus on the measurable spectrum of disease burden reduction. Analyzing mid-season epidemiological data carries structural limitations that public health officials must mathematically correct for. The primary confounding variable that skews these interim estimates is observational bias. Individuals who proactively seek out vaccines also exhibit other protective behaviors, such as high health awareness and specific dietary habits. This is known as the healthy user effect. This compounding health consciousness makes it difficult to isolate the standalone efficacy of the vaccine from the patient's generally healthy lifestyle. Failing to account for this bias can lead to an artificial inflation of top-line efficacy reporting during the early weeks of the season. A second variable injecting noise into the mid-season data is vaccine strain mismatch. When the rapidly mutating circulating strain deviates from the forecasted vaccine strain, the statistical confidence interval widens, resulting in a decay in overall efficacy. Due to these structural biases and strain mismatches, interim estimates function as directional risk signals for the current season. Moving from statistical analysis to clinical application requires an actionable, multimodal public health protocol. The vaccine is the foundational layer of a broader, synchronized defense strategy. Layer 1 focuses on a precise inoculation window spanning from October to November. Securing inoculations strictly within this window is the optimal temporal strategy for the 40 to 70 demographic. This timing ensures that peak antibody titers, the concentration of antibodies in the blood, coincide with the peak weeks of viral circulation in midwinter. Layer 2 introduces strict baseline environmental hygiene to support the vaccine's effectiveness. This requires a 20-second mechanical hand-washing protocol around environmental transition points, such as returning home or prior to eating. The physical friction of soap and water destroys the viral lipid envelope, neutralizing the vector before it can reach the respiratory tract. Rigorous environmental protocols reduce the initial viral load a patient faces, increasing the probability that the vaccine's primary mucosal barrier will hold. The final layer on the protocol flowchart is the threshold-based clinical trigger. If the primary barrier fails and respiratory symptoms such as fever and cough appear, rapid medical consultation is required. For the 40 to 70 demographic, particularly those with pre-existing conditions, immediate clinical intervention is a priority. Immediate antiviral or supportive intervention provides a final layer of protection to secure the 30% reduction in severe complications. The resulting protocol is synchronized: strategic vaccination timing, aggressive mechanical hygiene, and rapid clinical triggers working in tandem. Executing this multimodal strategy across the vulnerable 40 to 70 demographic restricts severe disease and protects the capacity of the broader healthcare infrastructure.